Good morning, everyone. Welcome to another Virtual Rheumatology Learning Collaborative webinar. We are very excited for your participation. My name is Elena Gruzman, and I'm a Rheumatology Fellow at Hospital for Special Surgery in New York, and my co-moderator today is Dr. Karina Torralba from University of Loma Linda. We are very happy to introduce our speaker for today, Dr. Sarah Gonglin, who will be talking about antiphospholipid syndrome. Dr. Goglin is an assistant professor of medicine at University of California, San Francisco. She attended Columbia University for medical school and completed her medicine residency and rheumatology fellowship training at UCSF. She's passionate about medical education and has multiple educational leadership roles at UCSF, including serving as an assistant program director in the medicine residency, an associate program director in the rheumatology fellowship, and the Associate Chief of Education in the Division of Rheumatology. Outside of work, Dr. Goglin enjoys spending time with her 3 young daughters and her husband. Dr. Goglin will be talking about antiphospholipid syndrome, the pathogenesis, and clinical manifestations. She will use cases to highlight complexities and nuances of treatment decisions in the management of patients with APS. Dr. Goglin, welcome.
All right, thank you so much for that kind introduction. It's really a pleasure to be here speaking to all of you this morning over this format. So as Elena said, I'm going to be talking about antiphospholipid syndrome, complexities and management for the rheumatologist. And this is a topic that I'm really passionate about and love taking care of these patients in clinic. So I don't have any relevant disclosures. So I think the first thing is just to take a step back and ask ourselves, why are we talking about this problem in rheumatology? You know, sometimes I get the question from learners, you know, isn't this a hematology problem? Why do I need to worry about this as a rheumatologist? And hopefully I don't have to convince all of you who are listening this morning that this is something I feel we should be very well versed in as rheumatologists. Obviously, it's a problem that affects many of our patients. We know that in particular, patients with lupus, up to 40% or so will have positive antiphospholipid antibodies, and a significant minority will have antiphospholipid antibody syndrome. And we often get involved with patients that have primary antiphospholipid syndrome when the management becomes more complex and we're considering the use of immunosuppressive therapy for refractory disease. So I would argue that we should be as well versed, if not more so, than the hematologists in taking care of patients with this disease. So objectives for my talk this morning, the first is to have you be able to describe the clinical manifestations and pathogenesis of APS, describe the risk of thrombosis in patients who are antiphospholipid antibody positive, compare and contrast the management of venous and arterial APS, describe the management of APS in pregnancy, apply the evidence that we're going to discuss to choose the most effective anticoagulant for treatment of APS, and then finally evaluate a patient with features concerning for catastrophic antiphospholipid syndrome. So as you all know, the antiphospholipid syndrome was originally described by Dr. Graham Hughes in the early 1980s, and his case series at that time was characterized by patients with clinical features of arterial and or venous thrombosis, recurrent pregnancy losses, and thrombocytopenia. And since that time, over the subsequent decades, there's been an evolution in our understanding of this clinical spectrum, realizing that patients can have asymptomatic presence of autoantibodies all the way to the other end of the spectrum with catastrophic multi-system organ failure. And we have also come to understand that this can be a primary disease or occur in concert with another autoimmune disease, most commonly lupus. So if you take a look just briefly at the history of how we have come to the current situation in our understanding of antiphospholipid syndrome, in the early 1900s, the diagnostic assay was developed to detect patients who were suffering from syphilis. About 3 or 4 decades later, it was understood that cardiolipin was actually the major antigen for the reagent in the syphilis assay, and that led to this understanding of the biological false positive syphilis assay. Over time, we understood that patients had prolonged clotting times and the occurrence of thrombosis And then subsequently, the antiphospholipid syndrome was described with other antigens such as prothrombin and then anti-beta 2 glycoprotein recognized later on in the 90s and 2000s. So the Sapporo and Sydney classification criteria are all familiar to you. So first, patients have laboratory criteria as outlined on this slide. So either a lupus anticoagulant, an anticardiolipin antibodies at moderate to high titers, and or an anti-beta 2 glycoprotein 1 antibody, again at high titers. And then a clinical criterion. And the clinical criterion include either thrombosis, which can be arterial, venous, or small vessel, or pregnancy-related morbidities. And the pregnancy-related morbidities include unexplained miscarriage at greater than 10 weeks of gestation, a premature birth before 34 weeks of gestation, or 3 or more unexplained consecutive miscarriages before 10 weeks of gestation. And obviously for these, we're needing to exclude other known causes of those pregnancy-related morbidities. Sorry. Okay, so a slide or two on disease pathogenesis before we dive into going through some cases together. So this is from a nice paper from the New England Journal a couple of years ago, proposing different mechanisms of pathogenesis in the antiphospholipid syndrome. So first, hemostatic reactions are known to be abnormal, both in terms of coagulation with acquired protein C resistance and inhibition of tissue factor pathway inhibitor, as well as abnormalities in fibrinolysis with inhibition of TPA activity and inhibition of fibrinolysis. Secondly, activated cellular elements are known to play a role with activation of endothelial cells, monocytes, and platelets all playing a major role in the pathogenesis of this disease. And then thirdly, and very importantly, there has been a increasingly recognized role of complement activation, which informs some of the treatment we use in refractory disease, leading to induction of thrombosis, activation of endothelial cells, and this pro-inflammatory environment being shown to lead to placental inflammation and dysfunction, leading to fetal loss. And these mechanisms here are outlined in the panel on the right for you. So our first case, we're going to talk about the scenario of positive antiphospholipid antibodies without thrombosis and the risk of subsequent thrombosis. So you have a 23-year-old woman with lupus who has triple positive APL, so is positive for lupus anticoagulant, anticardiolipin antibody, and beta 2 glycoprotein 1 antibody. And she asks you what her risk of developing a blood clot is. How do you counsel her about this risk? So what do we know about the development of thrombosis in patients who are APL carriers? So this study, published in Lupus in 2017, is the largest prospective cohort of APL carriers that was followed for the longest period of time. And they looked at about 100 patients who were positive for antiphospholipid antibodies, but who had had no known thrombosis at the onset. And what they found is that there was an annual rate of first thrombosis of about 2.3% per patient year. And that's compared to about 0.5 to 1 per thousand per patient year in the general population. And over time, they followed patients on average for 15 years. The cumulative risk of first thrombosis, as you can see here in this graph, was about 30%. When they looked at what were predictive factors of thrombosis in these individuals, they found that the baseline characteristics, which is outlined here in this table, were not predictive of first thrombosis, and that includes their antiphospholipid antibody profile, again, at baseline. There was a trend towards increased risk for thrombosis in patients based on their number of cardiovascular risk factors, but this didn't reach statistical significance. Of note, the antiphospholipid antibody profile at the end of follow-up, so at the time when they had their thrombosis, was more relevant than their profile at detection in predicting the risk of first thrombosis, which you can see here. And persistently positive antiphospholipid antibodies were significantly associated with an increased risk of first thrombosis as well. And of note, those patients who were triple antiphospholipid antibody positive had a threefold increased risk of first thrombosis compared to the other groups. So based on that data and then other studies as well, when you're thinking about the risk of thrombosis in your patients that have antiphospholipid antibodies, I think using this risk stratification can be helpful. So first, what is their antiphospholipid antibody profile, both in terms of the type of antiphospholipid antibody that they have and the titer. And it seems that the patients who are at highest risk are those who are lupus anticoagulant positive and or who are triple positive as outlined in the previous study. Secondly, what's the profile in terms of persistence? As we just saw, those who have persistently positive antibodies at high titers are at higher risk. And then really importantly in our patients, what are the other prothrombotic risk factors that they have and which ones are modifiable? So these things include underlying lupus, other genetic thrombophilias, traditional cardiovascular risk factors, transient or acquired risk factors such as smoking, surgery, oral contraceptive use, and then comorbid conditions such as pregnancy or nephrotic syndrome. So all things that might increase their risk on top of their antiphospholipid antibodies. And then to have some numbers in your mind, because I think these can be helpful as we're talking with our patients, counseling, and then thinking about what we might do to try to modify their risk. So for patients who are otherwise healthy, but have the presence of antiphospholipid antibodies, the risk appears to be perhaps less than 1% per year. This is in contrast to women who have a history of recurrent fetal loss. The risk of developing thrombosis is up to 10% per year. And in those patients who have had a venous thromboembolic event, who have discontinued their anticoagulation within the past 6 months, that risk is over 10% per year. And then again, according to the type of antiphospholipid antibodies, those patients who are positive for the lupus anticoagulant, the odds ratio for venous thrombosis has been shown to be on the order of 6, and arterial thrombosis an odds ratio of about 3.5. And then you can see here in this paper from blood, triple positive antiphospholipid antibodies, an odds ratio of 33 for thrombosis, so quite a bit higher. There's a scoring system that was developed by investigators primarily out of Italy called the Global APS score, which is a composite score to predict complications. And this was shown in a couple of papers to predict the incidence of thrombosis better than looking at the antiphospholipid antibody profile alone. So this takes into account not only their antibody status, but also other risk factors, including hyperlipidemia and hypertension. So based on that counseling, she wonders if there's anything that she should do or can do to reduce her risk of thrombosis. So what can we recommend to this patient and what is the evidence base for it? So the APLASA study is the only randomized controlled trial of primary prevention in asymptomatic antiphospholipid antibody positive individuals. And in this study, just under 100 patients who were positive for the lupus anticoagulant or for anticardiolipin over 20, so they didn't have to have high titers of anticardiolipin, were randomized to low-dose aspirin or placebo, and they were stratified by low and high risk. So this took into account other risk factors for thrombosis, the presence or absence of lupus, et cetera. And they followed them on average for just under 2.5 years. So not a very long follow-up period, which I think is important as we're considering the results of the study. So what they found over those just over 2 years of follow-up on average was that there was no significant difference in the risk of first thrombosis in the group that was treated with aspirin versus the placebo group. However, I do think it's very important to keep in mind that the overall event rate in both of these groups was low, and in general, this was a relatively low risk group when you looked at their autoantibody profile, the prevalence of lupus and the severity of lupus that they had, and also other risk factors for thrombosis. This paper, in contrast, so not a randomized controlled trial, but a very well done patient level data meta-analysis, looked at pooled data from 5 cohort studies of antiphospholipid antibody carriers for a total of just about 500 patients. The nice thing about this meta-analysis, because they had patient level data, they were able to adjust for traditional cardiovascular disease risk factors. And what they found in this study is that there was a 2-fold reduction in the risk of first thrombotic event in the patients that were treated with aspirin here in red compared with those that were not treated with aspirin here in blue. So again, not RCT level data, but a well-done meta-analysis which conflicts in terms of its results with the one RCT that we do have. So how should we think about primary prevention then in asymptomatic APL patients without lupus? And then on the next slide, we'll talk about those with lupus based on this data that we do have. So as we said, for low-dose aspirin, we don't have any prospective data to support empiric therapy. There is a statistically significant increase in the risk of major annual bleed. Hydroxychloroquine was attempted to be studied, but the RCT was terminated early due to lack of seen effect. So the recommendation currently is to consider low-dose aspirin in APL patients with a high-risk profile and or presence of other thrombotic risk factors, but that the benefit is uncertain. So really leaving this up to you in a risk-benefit discussion with your patient. And I think very importantly, focusing on modification of other risk factors such as hypertension, hyperlipidemia, diabetes, and then avoidance of estrogens, which often comes up in our patients when we're thinking about contraception. So what about in patients with lupus? How can we think about primary prevention there in those patients that are positive for antiphospholipid antibodies? So as we saw, there's no prospective randomized controlled trial data to support the use of prophylaxis. We have observational studies that suggest benefit for both low-dose aspirin and hydroxychloroquine. So the current recommendation from the APS task force is to consider low-dose aspirin and hydroxychloroquine in moderate to high titer antiphospholipid antibody patients with lupus. I think the hydroxychloroquine recommendation is an easy one because all of our lupus patients should be on that regardless of their antiphospholipid antibody status. The low-dose aspirin, I think, we don't have extremely high quality data for this. So again, it's still a decision, shared decision making between you and your patient. Because, just as an example, the thought of taking a 20-year-old woman and putting her potentially on aspirin indefinitely or for life, is not a decision to be made lightly. And again, focusing on modification of other risk factors remains extremely important. So case 2, we're going to move on and talk about treatment of thrombotic antiphospholipid syndrome. So no longer talking about primary prevention, but now talking about secondary prevention. So we have a 34-year-old woman with lupus who presents with a left MCA stroke. She's found to have a positive lupus anticoagulant by Russell Viper venom testing and a positive beta-2 glycoprotein 1 IgG. And based on this, her clinical presentation and positive antiphospholipid antibodies previously as well, she's diagnosed with antiphospholipid syndrome. She started on a heparin drip and warfarin. So what would be her target INR, and what might we do if she presented with a DVT instead of a CVA? So when we're making these decisions, there's somewhat of a disagreement in the literature, at least between hematology and rheumatology. So let's go through that data together. So there is some controversy, as I said, in how we think about anticoagulation intensity in patients who have antiphospholipid syndrome. When you look at the rheumatology literature, there are multiple small to medium-sized retrospective studies that come down on the side of high-dose warfarin. So this is when we're thinking about INR targets, usually in the 3 to 4 range. And we'll look at some of the data showing that high-dose warfarin is superior to lower dose or standard intensity therapy in preventing recurrent thromboses. But these are all retrospective studies with the usual questions about retrospective analyses, and issues of confounding and bias. In the hematology literature, in contrast, there's a randomized controlled trial, so high quality data showing no difference in risk of recurrent thrombosis with standard intensity versus high dose warfarin. So we'll talk about all of these things in more detail over the following slides. So this table comes from one of the major retrospective analyses that I mentioned out of the rheumatology literature. So an old study now published in the New England Journal in the mid-1990s, in which they looked at standard intensity warfarin with an INR of 2 to 3 compared with high intensity warfarin with an INR of over 3. And if you focus here, what you'll see is that in this study, they found a greater than 10-fold reduction in events in people with a higher INR target compared with a lower INR target. They also looked at adding aspirin, which did not have a significantly increased effect. And you can see here that in the same study, when they looked at long-term event-free survival, and this top line here in the group that was in the high dose warfarin group, there was a significantly lower rate of thrombosis compared with the other groups here, which is pretty striking. This is in contrast to what the best data that we have in hematology in this RCT, the Crowther study from the New England Journal in 2003. This is a randomized controlled trial, so in contrast to the retrospective data that we just looked at, in which they followed patients for 2.5 years. They did very frequent INR monitoring, so we have a very clear sense of when they were at target or not. And they randomized patients to warfarin with an INR target of either 2 to 3, which is the moderate intensity group, compared to an INR target of 3 to 4, which is the high intensity group. And what they found is that high intensity warfarin was not superior to moderate intensity warfarin in terms of preventing recurrent thrombosis. There were some issues with this study, though, that I think are important to keep in mind as we're taking care of individual patients. So first, they didn't have as many thromboses as they expected to see in this study, potentially because these patients were lower risk, so they actually had to change some of the rules midway to extend enrollment. As a result of this, the duration of follow-up for the final patient was reduced from 2 years to 6 months. So not a lot of time, even at the 2-year mark, potentially, to see many thromboses based on what we know about the risk of thrombosis in these patients. They excluded patients with a history of recurrent events. So inherently, this was a lower risk group than many of the patients that we take care of as rheumatologists. And also, there were fewer patients that had arterial events, and one of their exclusion criteria was recent stroke. So I think just important things to know, again, as you're deciding about treating your individual patient, because there are nuances that apply. And I think another major issue with the Crowther study is based on the fact that many of the patients who were in the high intensity group here were below target the majority of the time. So you can see what this slide is showing is that in the moderate intensity group here, the patients were at their INR target of 2 to 3, 71% of the time, and below that 19% of the time. That's compared with the high intensity group where they were in that high intensity target range of 3 to 4 only 40% of the time, and were below the target 43% of the time. So in some ways, this trial is actually comparing moderate intensity to moderate intensity warfarin, because many of the patients were not actually in that high intensity group, the bulk of the study. Obviously this is something that we face in real life with warfarin, and the difficulties with getting patients to their therapeutic target and keeping them there. But I think it's important as we're kind of extrapolating the results from the study. And importantly as well, most of the thromboses that occurred in the high intensity group took place when the INR was subtherapeutic or below the 3 to 4 range. So based on the data that we have, how should we think about secondary prophylaxis in patients that have antiphospholipid syndrome? So for patients who have had venous thrombosis and we're thinking about secondary venous thrombosis prevention, there are clear guidelines and good data to recommend initial therapy with either unfractionated or low molecular weight heparin, followed by long-term anticoagulant therapy with a vitamin K antagonist. So it's just warfarin with a target INR of 2 to 3. And then, as I said, the higher intensity warfarin therapy of INR 3 to 4 didn't further reduce the risk of recurrent thrombosis in the randomized control trial that I showed you, in addition to a second one. I think it's a little bit trickier when we're considering patients who've had arterial thrombosis and thinking about secondary prevention in those groups. Again, the standard of care is to use heparin and then transition to a vitamin K antagonist such as warfarin. There are some experts that prefer higher intensity warfarin therapy with an INR of 3 to 4 based on this retrospective data that I showed, as well as the fact that there were few patients with arterial thrombosis enrolled in randomized control trials. We don't have RCT data to support this higher INR target, but I think it's something to consider as we're taking care of these patients. There's also some data that I didn't present, but just to be aware of, that aspirin monotherapy may, with may in italics here, may be sufficient in older adults who've had stroke and have very low titer anticardiolipin antibodies, but really otherwise aspirin monotherapy is not sufficient for treatment of stroke in patients with antiphospholipid syndrome. Okay, moving on to antiphospholipid syndrome and pregnancy. So we have a 24-year-old woman with antiphospholipid syndrome manifested by a positive lupus anticoagulant test and a brachial artery thrombosis in the past. She's maintained on warfarin and she's planning to conceive. So just to think about this question, in your mind, in addition to stopping warfarin and starting low-dose aspirin, what other medications would you recommend for this patient during pregnancy? And our options are full-dose low molecular weight heparin, full-dose low molecular weight heparin and hydroxychloroquine, prophylactic dose low molecular weight heparin, and prophylactic dose low molecular weight heparin and IVIG. So how do we think about the management of antiphospholipid syndrome during pregnancy? So the first thing to remember is that warfarin is highly teratogenic. So should be discontinued prior to pregnancy when a patient's trying to conceive or immediately upon becoming pregnant. It also necessitates, because you're discontinuing it, starting another form of anticoagulation. But that dose is going to depend on their manifestation of APS. So when we think about patients who have obstetric APS, so these are individuals that have not had arterial or venous thromboses, but have had one of the pregnancy morbidities that I outlined earlier in the talk, there is data showing that the combination of heparin and aspirin is superior to aspirin alone in enhancing live birth and obstetric APS. And that's outlined here in this forest plot when they looked at multiple studies. So one being this line here in the middle, to the left favoring aspirin, to the right favoring heparin and aspirin. And you can see that all of the studies have come down here on the right-hand side. And overall, patients who are treated with heparin and aspirin were shown to be 1.3 times more likely to have their pregnancy result in a live birth than patients who received aspirin alone, with a number needed to treat of 5.6 to result in one live birth. There's also evidence that this combination reduces risk of preeclampsia in this high-risk group. So the important things to know is that the dosing of heparin that's recommended varies depending on whether a patient has had obstetric-only APS or thrombotic APS with either venous or arterial thrombosis. So you can see here on the left column, in patients who've had obstetric APS, we use prophylactic dosing of unfractionated heparin, or more commonly in the United States, low molecular weight heparin, plus a low dose aspirin. There is a recommendation to continue this regimen for approximately 6 weeks postpartum because of the increased risk of thrombosis in this period of time. And then after that time period, they would come off of anticoagulation altogether because, again, these are not patients who have had thrombotic events. This is in contrast to patients who have thrombotic APS. So these would be patients who had been usually maintained on warfarin prior to pregnancy, then would be transitioned to typically full dose low molecular weight heparin when they're trying to conceive, and then maintained on that for the duration of their pregnancy in combination with low dose aspirin. And then they would be transitioned back to warfarin after delivery. Another important thing to keep in mind is that warfarin, as well as the heparins, are compatible with breastfeeding. So don't forget, to transition your patients, in concert with their hematologist or whoever it is that manages their warfarin, transition them back to warfarin after delivery so they're not continuing injections unnecessarily. So for this patient, the appropriate recommendation would be full dose, low molecular weight heparin for treatment of her antiphospholipid syndrome. Again, she's had an arterial thrombosis, so she would merit the full dose anticoagulation. If, for example, she had not had an arterial thrombosis and she had had recurrent pregnancy losses, then we would use prophylactic dose low molecular weight heparin. And just to know, we're putting all of these patients on low dose aspirin as indicated in the questions. Okay, so we talked about the prophylactic dose low molecular weight heparin here. In terms of hydroxychloroquine, there's some promising retrospective data, but no prospective data to support its routine use in antiphospholipid patients without lupus, so it's not routinely done. And then in terms of IVIG, there are especially some reproductive immunologists that advocate for IVIG in women who have positive antiphospholipid antibodies and either prior pregnancy losses or infertility. But there have been a couple of small RCTs done that have not shown improvements in outcomes. So it's not recommended, certainly as first-line treatment for these patients. Okay, moving on to our next case, which is thinking about the use of direct-acting oral anticoagulation in patients who have antiphospholipid syndrome. So for this case, we have a 42-year-old woman with lupus who's coming to see you in clinic for follow-up. She was diagnosed with a new left lower extremity DVT 3 days ago and was started on rivaroxaban in the emergency department. Her past medical history is notable for an ischemic CVA last year, for which she takes aspirin. On exam, when you see her, her vital signs are stable. She has no calf tenderness, but does have obvious livedo reticularis of the upper and lower extremities. So her lab testing from 4 months ago revealed the following. Focusing here on her antiphospholipid antibody, she has high titers of both anticardiolipin IgG and IgM, as well as beta-2 glycoprotein IgG and IgM, and is positive for the lupus anticoagulant. So she would be considered triple positive. So what recommendation should you make as her rheumatologist about her anticoagulation regimen? Would you continue her rivaroxaban without change, switch her from rivaroxaban to dabigatran, switch her from rivaroxaban to warfarin, switch her from rivaroxaban to enoxaparin, and bridge to warfarin? So obviously, as we talk about the answers to this question, we're not usually doing this in isolation as rheumatologists, but often because our patients see us, much more frequently than they see their other doctors, we may be the one to pick up on the fact that there are nuances in this treatment decision that need to be taken into consideration. So the direct oral anticoagulants, just to quickly review what these are. So there's a direct thrombin inhibitor, currently dabigatran, it's available. And there are direct factor 10A inhibitors. So rivaroxaban is one of these, as well as apixaban and edoxaban. And these are currently approved for a few indications in the primary treatment and prevention of venous thrombotic events, the prevention of stroke and systemic embolism in patients who have non-valvular heart disease, and the treatment of acute coronary syndromes. However, it's very important to keep in mind that in the major clinical trials that studied these medications compared with warfarin in venous thrombotic events, APS status was not documented. So from those initial trials, we really didn't have any evidence in those patients. So this is a very important study to be aware of that was published in the Annals of Internal Medicine last year, which compared rivaroxaban to vitamin K antagonists, most commonly warfarin, in the treatment of patients who have antiphospholipid syndrome. It was a 3-year open label, non-inferiority randomized control trial. And the important point here is that rivaroxaban was not shown to be non-inferior to vitamin K antagonists. Stroke was seen more commonly in patients treated with rivaroxaban with a relative risk of 19, although you can see a wide confidence interval here of 1 to 320. There was a potentially increased risk for recurrent thrombosis in those patients that were treated with rivaroxaban who'd had previous arterial thrombosis, who had libido racemosa, or who had APS-related cardiac valvular disease. And you can see here that the rates of thrombosis in the rivaroxaban group approached 12%, compared with 6% in the vitamin K antagonist treated group, with a relative risk of 1.8. This confidence interval did cross 1, so it's not a statistically significant difference, but is concerning, and most importantly, rivaroxaban again was not shown to be non-inferior to vitamin K antagonists. And this confirmed concerns that had been seen in other studies, either cohort or other types of observational design, as well as randomized controlled trials that had been terminated early due to increased risk of arterial events in patients that were treated with the DOACs. So I think at this point in time, based on this data, these agents should not be used certainly as first-line treatment to replace warfarin in patients who have antiphospholipid syndrome. They may potentially have a role for treatment of patients who have lower risk APS, potentially who've had like a single venous thrombotic event, but we do not have data to support this at this time, and await the results of further clinical trials. So warfarin remains, standard of care for these patients. So for this patient, we would want to switch her off of her rivaroxaban, and just an important reminder that the enoxaparin would be used as a bridge to warfarin until she gets to her target INR. Okay, so our last case is thinking about catastrophic antiphospholipid syndrome, which is, I think, something that strikes fear in all of our hearts when we get these consults in the hospital or when we're asked about the possibility. So this is a complicated case, but I use it because when we're seeing these patients and considering this diagnosis, it's always complicated. So this is a patient I took care of, a 32-year-old woman who was hospitalized after a recent delivery. She'd been hospitalized at 28 weeks of pregnancy with new onset proteinuria and hypertension, and had been diagnosed with preeclampsia. Shortly after that, she developed generalized seizures and was diagnosed with eclampsia and underwent an emergent C-section. Now, 3 days after delivery, she's getting worse. A CT scan of her abdomen showed a normal sized spleen and a liver with a 3-centimeter area of infarction. Also has unstable pulmonary status and requiring supplemental oxygen. She had had no other systemic symptoms aside from her typical pregnancy symptoms. Importantly, she'd had 3 prior pregnancies, including a loss at 13 weeks of gestation and a preterm delivery due to preeclampsia at 25 weeks a couple of years ago. She'd never had hypertension or proteinuria except for during pregnancy. And on exam, she was tachypnic. Her blood pressure was elevated at 142/82. She had crackles in both of her lung bases, was tachycardic with a 2 out of 6 systolic murmur, had abdominal tenderness, particularly in the right upper quadrant, was noted to have multiple splinter hemorrhages in her fingers and toes under the nail beds that were new, as well as a new confluent petechial rash over her shins. Her neurologic status at this time was normal. And she was found to have a positive anti-nuclear antibody, which was what prompted the consult to you as the rheumatologist. And her labs, when you reviewed them, were quite concerning. So in this second column here, we have her labs earlier on, and then at this time 3 days after admission. So she has a marked elevation in her transaminases as well as her bilirubin. Her creatinine has increased from 0.7 to 4.2. She has worsening anemia. White blood cell count is relatively stable. Mild thrombocytopenia, and a urinalysis with hematuria, pyuria, and proteinuria. So a complicated case. I think you all know the answer to this question because of the context in which I'm giving this talk. But the question we would be asking ourselves when we're seeing the patient is, which test would be most likely to clarify this patient's diagnosis? So an Adams TS13, anticardiolipin and anti-beta-2 glycoprotein 1 antibodies, anti-double-stranded DNA antibody, anti-Smith antibody and complement levels, or natural killer cell activity, ferritin level, and a soluble CD25. So this is a patient who is presenting with clinical features that are very concerning for catastrophic antiphospholipid syndrome. So this is a thrombotic microangiopathy in which we see multiple, either simultaneously or in rapid evolution, thrombotic events that involve microvasculature throughout the organs in the body. And the clinical manifestations vary significantly. With the kidneys, you can see very severe hypertension and acute kidney injury. From the standpoint of the lungs, patients may have ARDS or diffuse alveolar hemorrhage. Hematologically, again, this is a thrombotic microangiopathy, so patients may have microangiopathic hemolytic anemia, thrombocytopenia, or signs of DIC. In terms of cutaneous manifestations, splinter hemorrhages are often seen, lipidoreticularis or racemosa, or digital necrosis in very severe cases. Cardiac involvement can occur as well with systolic cardiac dysfunction, myocardial infarction, valvular lesions, or atrial thrombus. This can be the presenting manifestation of antiphospholipid syndrome in patients, so you really have to have a high index of suspicion when you're seeing patients with microangiopathic hemolytic anemia or a TMA to think about this. And the overall prevalence rate is thought to be about 1% of all patients who have APS. So not common, but highly morbid and a high mortality rate. So in terms of the thrombotic manifestations that we see in CAPS, I alluded to some of these on the previous slide, but just to point out here a few things. So renal involvement seen in about 70 to 75% of patients, so very common. Pulmonary involvement, neurologic involvement, cardiac involvement, and cutaneous involvement also being very common in the 50 to 60% range. Also important to point out that macrovascular thrombosis can occur, but relatively uncommon in these patients compared to, of course, patients that have classical APS. But you can get a sense here, really, the fact that essentially any organ in the body can be affected. So the classification criteria, and again, these are classification criteria, not diagnostic criteria, but these state that patients have at least 3 organs or tissues that are involved with less than or equal to 1 week of progression of disease, ideally with histologic, pathologic histopathologic confirmation of microvascular thrombosis in at least one tissue, and then lab confirmation of antiphospholipid antibodies, usually in high titers. And then there's a scoring system here in which patients can be classified into either definite CAPS or probable CAPS. I don't think these things are important for clinical care, but these criteria, I think, help you keep in mind kind of the key features of this condition. So precipitating factors of CAPS are important to keep in mind, both in terms of identifying factors that you could intervene on in a patient that has CAPS, and also scenarios in which you would have a heightened suspicion for this. So infections have been shown to be precipitating factors in about a third of patients, surgery and other invasive procedures in about 13%. In this patient, obstetric complications or pregnancy, also a known trigger, and then no factor identified though in about a third as well. So a smattering of different triggers here, but often in many cases you still won't be able to identify a trigger. The prognosis of this condition is poor. So in earlier series, the mortality approached 50%. This may be improving, but still high in the order of 30% as we are more aware of this condition and treat these patients more aggressively. There are features that are known to be poor prognostic indicators. So older age at diagnosis, more involved organs, and then specifically if patients have splenic, cardiac, or intestinal involvement, they're at higher risk for mortality from CAPS. This is a proposed treatment algorithm for patients who have been diagnosed or suspected to have catastrophic antiphospholipid syndrome. So the first thing is just the importance of recognizing it. So if you have a patient who has acute multi-system involvement who's critically ill with features of a microangiopathic hemolytic anemia, don't forget about the possibility of CAPS as a potential cause. And then in those patients who are found to have positive antiphospholipid antibodies, especially at high titers, your suspicion is very high for CAPS. Then we think again about an active search for precipitating factors that we talked about, and specifically in our patients who have lupus, in which there's evidence of disease activity, cyclophosphamide may have a role in the treatment of these patients. Think about ICU level care for these patients if they're not already there, given the fact that these patients can get very sick very quickly. And then stratifying them by the severity of their disease. So if patients have life-threatening disease, if they have severe cardiac or neurologic involvement, then this group would recommend treatment with heparin, as well as pulse steroids, and consideration of rituximab, plasma exchange, and IVIG. If patients have less severe disease, then using just heparin and glucocorticoids up front, but not moving on yet to rituximab, plasma exchange, and IVIG unless they were to clinically worsen as suggested here. And then looking at, after aggressive treatment here for clinical improvement, if they are getting better, then thinking about rapid tapering of steroids and long-term anticoagulation. If they're not getting better, then consideration of eculizumab, which is a monoclonal antibody against complement C5, which prevents downstream formation of the membrane attack complex and activation of complement, which we know is important in this disease. So just to make the point that heparin and glucocorticoids are the cornerstone of treatment for all patients with catastrophic antiphospholipid syndrome, but then, out of desperation in these very critical ill patients, considering rituximab, potentially eculizumab, plasma exchange, and then cyclophosphamide, particularly in patients who have lupus. So for this patient, she had core clinical features that were concerning for a thrombotic microangiopathy, and catastrophic antiphospholipid syndrome. Just to do some teaching quickly before we move on to questions about the other answer choices. So the ADAMS TS13 test would be a test that would clarify if a patient had TTP. She did not have core clinical features of TTP, although certainly there can be a lot of overlap in our patients with CAPS. So that would be unlikely in this case to help us with the diagnosis. Testing for ANA subserologies, because we know the positive ANA in this patient. Certainly it wouldn't be incorrect to send these, and we all would, but overall her history is really not consistent with systemic lupus, and there would be a higher index of suspicion at this time for CAPS than for a severe lupus flare based on everything that we know about this patient. And then finally, the last answer was getting at test for HLH or macrophage activation syndrome, and she lacked many of the key clinical features of this. So most likely to have catastrophic antiphospholipid syndrome based on everything we have gone for, and would likely have high titers of the antiphospholipid antibodies that were previously outlined. So just to wrap up here, we've gone through a lot together today. We touched on the clinical manifestations and pathogenesis of APS. You're now able to describe the risk of thrombosis in patients with positive antiphospholipid antibodies. Use that to counsel your patients and think about the potential role for primary prophylaxis in these individuals. We've compared and contrasted the evidence in the hematology and rheumatology literature for the management of venous and arterial APS. We've discussed the nuances of the management of antiphospholipid syndrome in pregnancy, depending on whether a patient has obstetric-only APS or thrombotic APS. We've discussed the evidence for the most effective anticoagulation method for secondary prophylaxis of APS, and then finally discussed how to evaluate a patient with APS. So thank you all so much for your attention, and I'm happy to take questions from the moderators.
Thank you so much, Dr. Goglin, for that talk. One of the comments that actually was generated as part of the Q&A was that this was one of the best talks ever on APS that person ever heard. So that's a compliment to you. So Elena, you're okay if I start?
Yeah, absolutely. Go ahead.
So we kind of went through the questions. There's a lot of questions, so we apologize in advance if we can't get to your question. A lot of them are pretty good questions. So we kind of lumped the questions together as diagnostics and some general questions and some therapeutic questions. So just to refine some of the points being raised by Dr. Goglin. So one of the questions, Dr. Goglin, that came up was, how frequent would you check for the APS antibodies, and what would you do in the setting of negative serologies, but yet the patient, you highly suspect somebody still has APS?
Yeah, it was a really great question. So for the first one, in terms of frequency, so, this applies, I think, most commonly in our patients with lupus. So my practice is to check at diagnosis or when they're establishing care with me. I then don't routinely recheck them on any kind of structured basis unless there's something clinically that's changing. I would say the most common scenario that comes up is either when I'm considering contraceptive methods with a patient or when they are considering pregnancy. And in both of those scenarios, I recheck antiphospholipid antibodies to help inform that discussion about options for contraception or thinking about what the potential risks are for pregnancy for an individual patient. So those would be the scenarios in which I routinely recheck them. Certainly if a patient had thrombosis, I would recheck them, but otherwise I don't recheck them on any sort of ongoing basis for individuals. The second question is about this entity of seronegative APS, which is a very difficult condition, when we're considering it in patient, obviously. We have all seen patients who, for all the world, look like they have APS and they are negative for our usual antiphospholipid antibodies and lupus anticoagulant. There are other autoantibodies that I didn't touch on just for purposes of time for this talk. So against the, for example, prothrombin and phosphatidylserine complex, which are known to be positive in some patients who have APS, but are not often available outside of a research setting. So usually in these patients, we collaborate with some of our colleagues in Italy who have the ability in their research labs to do an extended panel. But outside of that, it can be very challenging.
Another question that's come up frequently are how much value do you put into the IgA, ACL, and beta-2-glycoprotein tests as compared to IgM or IgG?
Yeah, so the specificity for the IgA antibodies is significantly lower than IgG or IgM, and that's why they're not included in the classification criteria for APS. I would say it really depends on the clinical scenario. So, you know, if I have a young woman who has lupus, who's had multiple thrombotic events and has a high titer anti-beta-2-glycoprotein 1 IgA, then I take that antibody seriously and I would make the diagnosis of APS. If I have someone, you know, with no history of thrombosis and only a positive IgA antibody of some type, you know, that's not someone that I would consider putting on a low-dose aspirin for primary prophylaxis. So it really depends on what the clinical situation is.
And then a couple more questions. Outside, let's say, of a case where you don't think a patient has lupus, is there any value in checking complements in the setting of APS by itself?
That is a good question. I mean, I'm not, it doesn't help me or others, I think, you know, diagnostically. There are some patients who have primary APS who will have hypocomplementemia, probably through the mechanism of complement activation that we talked about. And that's especially true during the time when they have an acute thrombosis. We don't usually see that, though, in times of disease quiescence when their APS is well controlled. So I don't routinely check it in those patients.
Okay. And then since I think there's some variation with the labs across the world on how they check the titers and everything, how would you kind of designate a low titer versus a high titer, and what would its significance be in terms of clinical decision making?
Yeah, so I wouldn't give kind of blanket numbers for low versus high titer to answer this question, because it varies, as you said, across the world and from lab to lab. So it's very important to know what's happening in your individual lab. I think what we do know is that regardless of what the numerical cutoff is, it's very clear that high titer autoantibodies, especially in combination, confer a higher risk for thrombosis than low titer autoantibodies. So the way that it impacts my clinical decision making is in patients in whom I'm considering primary prophylaxis. So this usually comes up in my lupus patients. If they have high titer autoantibodies, especially if there are multiple high titer autoantibodies or triple positive, those would be the patients in whom I would seriously consider recommending primary prophylaxis, compared with a person who has, you know, a low titer anticardiolipin IgM, just as an example.
Okay. I'm going to hand off some of the therapy questions. Elena, do you have any therapy questions?
Thank you. Thank you very much, Dr. Coughlin. So one of the questions was about management of patients who have recurrent arterial thrombosis or other thrombosis despite therapeutic INR. Do you usually add aspirin, or your goal is to increase the INR, or what is the role of Plaquenil or statin in those cases?
Yeah, it's a really good question as well, and one for which we don't have a significant evidence base. So you'll see a lot of practice variation here. I would say the first thing that I always do is to try to get a sense of what their INR trend has truly been, because often what we'll find is that these patients have not been even in that therapeutic range of 2 to 3. If someone does seem to have clotted through a kind of that moderate intensity level of warfarin, then usually my next step will be to increase their intensity of warfarin to the 3 to 4 range, or 2.5 to 3.5, depending on the specific clinical scenario. And often we'll add Plaquenil as well, just because, you know, in kind of as we're thinking about risks of all of these options, it's a relatively, you know, low risk medication to use for this condition. I don't usually add aspirin right off the bat to warfarin in these patients, just due to the increased risk for bleeding. If a patient is clotting through higher intensity warfarin, then typically my next step is to switch them to low molecular weight heparin for treatment and for ongoing prophylaxis against recurrent thrombosis as the next step there.
Thank you. I think we don't have any more time for questions. Dr. Goglin, thank you so much for joining us. Thank you to everybody who's with us today. This was a great lecture, and it will be available on the ACR website as well.
Great. Okay, thank you all so much.
Thank you very much.